Hello, welcome again to the episode in the Let Fuel Prosper series. My name is Dr. Vance Ginn. I hope you're having a prosperous day. Well, today I'm delighted to have someone on who's been on the front lines to talk about liberty, freedom, affordability, better care in health care across the country at the federal level, mostly at the state level. And so we've got a lot to talk about because as we all know, we're paying a lot for healthcare and we're not getting the best results that we could. So we've got a lot to talk about, and it's none other than Naomi Lopez. Naomi, welcome to the Let Fuel Prosper show.
Thank you. It's so great to be here.
Well, it really is a pleasure to have you on. We've been friends for a number of years and worked on a lot of different things. And so I'm delighted to have you on on this important topic. For the audience, let me go ahead and give them an overview of your bio and what you've been up to, and then we'll jump right into it. So Naomi Lopez is the founder of Nexus Policy Consulting, a senior fellow at the Goldwater Institute, and a public advisor to Paragon Health Institute. You'll remember, for the audience, we recently had on Brian Blaze, who is the president of Paragon Health Institute. We talked a lot about federal policy and healthcare policy. And so it's great to have Naomi on as well to talk now about more about the state policy, bringing both of those to light of what's going on. And we're recording this on September 13th, 2023, just in case something happens between now and when this airs. So you never know. You never know what's going on. Her work focuses on a broad range of healthcare issues, including the right to try, off-label communications, pharmaceutical drug pricing, supply-side healthcare reforms, the Affordable Care Act, Medicaid, and 21st century healthcare innovation. Naomi has 25 years of experience in policy and has previously served at organizations including the Illinois Policy Institute, the Pacific Research Institute, and the Cato Institute. She previously served as vice president for healthcare policy at the Goldwater Institute, leading the Institute's efforts to implement federal and state healthcare reforms that benefit all Americans. She's a frequent media guest and public speaker. She has authored hundreds of studies, opinion articles, and commentaries. She holds a BA in economics from Trinity University in Texas and an MA in government from Johns Hopkins University. Naomi, let's get started. The first question is, why do you do what you do every day?
So I'm really driven by solving complex problems. And there really is no policy issue more complex than healthcare, which is really what motivates me. It's insurance policy, it's tax policy, it's social welfare. It really intersects a lot of different policy areas in addition to being impacted by both federal and state policies. And so it really is, if you want challenge, go to health, go into the healthcare. There is a lot of opportunity there too, to have really positive impact. And so that really is what motivates me and drives me to focus primarily on healthcare policy.
Yeah, no, that makes a lot of sense. And you're right. It is very complex and complicated. And I want to get into some of that as we talk about this during our time together. But I wonder what got you to this point. I mean, I know I've went through some of your career and everything else, but did you always want to get into healthcare policy when you started, or what was that kind of journey like?
When I was an undergrad at Trinity in Texas, in San Antonio, and we're both Texans, I got really excited about microeconomics and applying economics to the current day issues. And so I deferred graduate school for a year. I had thought I was going to go into a master's program in the Midwest, but I deferred for a year and I went to DC to actually see policy, do policy. And during that time, I realized that I was going to learn far more by being in Washington, DC than sitting in a classroom in a graduate program. And so what I ended up doing was doing my degree at night part-time while working in policy. And I have to say, I mean, that was a fantastic opportunity to really see it, see what it's really like, see how it actually happens in real life. And that's really, served me well throughout these years in terms of understanding why lawmakers might vote a certain way, what their comfort level is, how public opinion drives votes and these narratives, and how do you create change? That's where it started. And of course, I learn every single day. There's always more to learn. I know a lot about healthcare policy, but I only know 1% of it. I mean, there's so much to know. So anyway, that's how I got started.
Yeah, no, that's great. And you mentioned economics, and I talk a lot about economics, as you know. When you're thinking about healthcare economics, there's so many factors, of course, going into that. In my master's program, well, I got my PhD in economics directly. I went from bachelor's to PhD, but in those graduate programs, one of the classes was healthcare policy. And we talked a lot about healthcare market and everything else and supply and demand. And it's interesting you mentioned more about the micro level, because I think at the micro level is really what we need to be thinking about between the doctors and the patients versus, I think we get so caught up though with the macro. I mean, that's really what's talked about in the media and everything else. But I wonder what some of your thoughts are between the micro and macro.
Well, so I think I love microeconomic policy, and I love how I like to say this, and it's not 100% true, but it's mostly true that no one in healthcare has clean hands.
Mm.
Not even the soccer mom who is taking her kids to get their ears checked for ear infections or the flu. Everyone wants a free ride in healthcare. And so you have the upper middle income soccer mom who is upset about paying $25 for a copay, and yet is probably spent that at Starbucks this afternoon. So you really do have a lot of misalignment of incentives. You've got no connection between the consumer and the value that they get out of what they pay between themselves and their employers. You've got a lot of disconnects where it's not a functioning market. There's less than 5% of the healthcare market that is actually free market in the sense that it's a cash market. So we've really got a lot of obstacles that really present themselves from the microeconomic perspective. But I'm very optimistic about moving forward and the ability of harnessing current technology, information, in order to get the right treatment to the right patient at the right time and actually drive down the cost of so many of these day-to-day services that we get. Obviously, we've got a lot of new technology and innovation in the medical sphere that is going to cost a lot more money, but I don't think we have to fear that, because I think if we really focus on the benefits of some of these treatments that are coming online, and some of them are actually cures, some of them have made cancers chronic conditions rather than death sentences, fortunately, in many cases. We've really got some great opportunities to have a much better healthcare system that reaches more people, that provides more access and far more affordability, especially for these routine type procedures that many of us are paying way too much for through the current insurance system.
Yeah, definitely. And you're right on when you talk about kids. I've still got 3 little kids that are ranging from 1 to 9. And we're going to doctor pretty often. And, those costs start adding up in a hurry. Fortunately, we're blessed to have income that we can pay for it, but a lot of people are not. And they see those costs continue to skyrocket. I know health insurance prices, I think over this coming year are expected to go up another 5%.
Oh, and I was going to say the value behind that is we're not, you're not seeing it. So we used to, my kids, one in particular, we always had the deductible because of asthma related issues. We always had the deductible. It wasn't until we were able to enroll in direct primary care locally, which is like a gym membership where you pay a monthly fee and you have access to a provider, that we actually stopped hitting the deductible. It's a very high value way to spend money on healthcare. And that really is the kind of reform and more of that nature that I think really can impact the quality of care that we get, the accessibility of that care, but not just for those of us who are fortunate enough to have an employer-based plan and can afford to spend extra, but actually for those workers who don't have the same predictable income either. I think that these are solutions that work well for a lot of different people, and especially those with chronic conditions. There are direct primary care providers in this country who provide the maintenance meds for free. The generic maintenance meds are free to their patients. We really have to think outside the box, continue to innovate, continue to make it legal to have better options. We know that recently the Biden administration proposed rules to further limit short-term limited duration plans, which are basically short-term policies to help people that are in between jobs and the like. And it's really unfortunate because so much work and success had gone into allowing people to move from market to market in the insurance area. And now the current administration is undermining that and limiting choice for those who need it the most. So I think that, there is enormous opportunity to, we've got a couple of things going on. We've got a battle against those who would want to limit choices and options for individuals and families. And then we've got to continue to innovate so that we have more options and opportunities to move forward.
Yeah, definitely. And a lot of good points there that I want to hit on throughout our discussion. I wonder, maybe an overarching part of all this discussion, philosophical discussion about healthcare is healthcare a right? And we hear that a lot, especially from the left, where they'll say healthcare is a right. And so this is why government needs to provide it. And it should be quote unquote free. We know nothing is free. There's always a cost here, but they'll call it, free. But I wonder what your take on it is, as you've been working this and you've been doing it for a number of years now, Naomi. I don't know how it's 25 years. It must start when you're 10 or something. But overall, we're doing this for a while, and I wonder what your kind of take on this idea of healthcare as a right.
So we as a society have made a determination that we do want to provide a safety net for those who are in dire straits and who really do need, for example, emergency care. We don't want people dying in the streets. And, I think that most of us agree on that. But I think that the real problem comes in when we think that government is going to be able to provide this. Would we want the government buying groceries for hundreds of millions of Americans? No, absolutely not. We all can agree on that.
Yeah, I would hope. Yeah.
So I think that, whenever people talk about it, I can understand, the desire that, there's a lot of uncertainty and a lot of fear around health insurance. There's a lot of fear around having a very high episodic costs. So that's a rational fear, I think, in some cases. But the reality is that when you're talking about healthcare as a right, are you going to compel the janitor to clean the operating room? Are you going to compel the nurses to work even if the annual budget for healthcare runs out? Are you going to force them to work for no pay? I mean, we really are, not talking about reality when we're talking about healthcare as a right. There may be a sentiment that we want people to get high quality care and we don't want people to be put in precarious financial situations over it. But that's not the same discussion. That's a different discussion.
Yeah, no, great answer there. And I agree with you. I think there's not a right to it. There are rights, God-given rights to us overall. And I think when government makes something a right, it also means that they have the right to take it away. And so there are two sides, right? Remember, Thomas Sowell said there's only trade-offs, there's not solutions.
Right.
And I think that's correct in this area as well. When there are trade-offs, like if you make something quote unquote free, the trade-off will be rationing. And how does the government going to ration it? Who's going to get the services first? Because prices, as you were mentioning earlier on microeconomics, prices are the best way to allocate resources efficiently. And that's what the market does best. Where Adam Smith talked about the invisible hand, coming together and people interacting voluntarily in those marketplaces allows for prices to go to those who value it most on both sides of the market, the producer and the consumer. And when you start to break all that up in healthcare, and Brian Blaze and I talked a lot about where it all started in employment provided healthcare and the subsidies and the tax breaks and all the stuff that goes along with that. Really got that started 30s and 40s, but that was also doing price and wage controls by government influencing that situation. And now we're got to the situation today where it's like, well, insurance prices are up, so we need Medicaid and Medicare to start directing resources as well. And so I guess this brings me into, what roles should government really have? I think we talked about a little bit, but is it lopsided more towards the federal level versus state level? Or what do you think about some of the dynamics that we see today?
Well, I think that, whenever we talk about wanting free market healthcare, we have to be very honest and understand that we don't have that. People will talk about government payer, single payer versus the free market. We don't have a functioning free market. We don't have price transparency. We don't have competition. We don't have the ability of the consumer to take their resources and choose something different. And so I think that that's where we have to start the discussion is, we've got to talk about the reality. The reality is that there are enormous government distortions. I think primarily they come from the tax treatment of employer-sponsored health insurance. That's probably the biggest distortion, but there are a lot of others. We've also got, for example, the 800-pound gorilla of Medicare determining what doctors are getting paid, for example, determining what coverages are going to be available for patients. You do have rationing there. People may not like to talk about it, but there is absolutely positively rationing in the Medicare program. When we talk about the state level, we really get more into the practice of medicine. For example, does the state allow pretty open telehealth services for their citizens? Does the state allow a nurse to practice at the top of their education and training? Are they allowed to write prescriptions for certain medications? Or certain classes of medications, for example. Are pharmacists allowed to do rapid strep tests and flu tests? we really have a whole lot of distortions in the healthcare market. And I do think that simple reforms, they're not simple to implement or to get across the finish line legislatively. If you had more choices, and particularly those in the public programs, to vote, to take their resources and choose something different, we would have a very different system, I think, very quickly. And so I think that we've got a whole lot of distortions, and in a lot of situations where the incumbent type of industry or players are writing the rules to these reforms. For example, we've got a lot of discussion around hospital price transparency, which I think is I think that there should be more transparency, and people should be able to know what the cost is for a service at a hospital. But the unfortunate truth is that the hospitals are very influential in writing these rules, and you end up you may have a great name or a great idea, but the reality of the reform isn't getting you to true transparency. What gets you to true transparency is allowing for making sure that price competition is legal.
Yes.
So that's a big difference. And we're really starting to see a whole lot of movement in the pharmaceutical space, which I'm really excited about. It's been a long time coming.
Yeah.
And I've done a fair amount of work on allowing consumers to really to transfer prescriptions using their smartphones, and without having to go to your pharmacy and beg them to transfer it for you because there's a better price somewhere else. You've got the entrants like Mark Cuban and Mark Cuban Cost Plus and Row Pharmacy, for example, and Amazon. And you've got these new players in the generic space in particular who really are going to be able to provide price transparency and true competition in this generic cash space. And the big box stores are joining in too. So that's how reform takes place. That's how you change and create transparency. There's not a bill in most cases to get you there. I mean, maybe you can, but in most cases, there's not a bill that you can write that's going to get you price transparency. It's really the dynamic of having options for consumers that are readily and easily available and letting them choose.
I think you're exactly right. There are a lot of pushes to have price transparency. I think they passed a bill in Texas. Yeah, lots of bills to force price transparency, which, at first I'm still hesitant that government should force companies to pose prices, but it's kind of like, well, why are they forcing prices? And government's already influencing hospitals anyway, so there might be a reason to do that. But the prices, I think you're bringing up a great point here. The prices that they would post are based on the manipulated price by government. Because in that market, if you think about supply and demand, the government is distorting the supply side by the FDA for drugs and patent laws and doctors and nurses, occupational licensing and things of that nature, and certificate of need laws and things of that nature. The supply side is being distorted to the left, keeping prices higher. And on the demand side, it's keeping it further to the right because of the subsidies and the tax breaks and different things that aren't reflective of the value that you're getting, which you mentioned earlier, Naomi, but based on what government thinks that we need, right? And so they're trying to, I guess in their mind, correct a market failure when really it's turned into, or is, a government failure on the demand side and a supply side, driving prices higher than otherwise they would be and creating the situation that we have all around us. But nobody wants to talk about it, it seems like, except for you and a few others.
Well, here's a great example of price transparency and competition. So the generic form of Singular is called Montelukast. It's a generic. A 30-day supply of 10 milligrams is about $120 for the list price. If you go to GoodRx, you're going to pay about $50 or $60 for a 30-day supply. Through my employer plan, it was about $16. But through my direct primary care provider, who got Montelukast through the mail, it was less than $1, including the price of the brown bottle, which was about a quarter. So think about like Mark Cuban and Row Pharmacy and Amazon and big box stores getting into this generic space. You can pass dozens of laws, but that's not going to get you the $1 price.
Yeah.
Mark Cuban, he's now offering a lot of different drugs for $5 and is now manufacturing some higher cost drugs that are dramatically changing the cost for patients who need it most. But that's what changes and drives transparency and competition, is when you actually have choices, when you can actually take your resources and go somewhere else. And so, for example, for Montelukast, I could have gotten it through my employer for $16, but why would I? I just paid $1. It didn't go against my deductible, but I didn't care. It was $1.
Right. That's exactly right. No, that's great points there, Naomi. I think when we're getting into the healthcare space for states, and I know a lot of the listeners will be wondering, okay, what can we do differently at the state level? There's not a lot they can do for Medicare. That's the federal level. That was created in 1965. The LBJ's kind of war on poverty, all those issues that came up, which talked about that as well. But there's a lot of issues that happened. But you also had Medicaid that was created then too, where the Congress, the federal government created it, but it's administered by the states. It's actually a pretty large share of their budget is Medicaid, and the healthcare part, especially over time, especially for those states that have expanded Medicaid under Obamacare. Which, how many states haven't expanded now?
I think they're probably like 8 or 10.
Yeah.
There are not many. I don't have an exact count.
Yeah, it's okay. That's what I was thinking as well. I know Texas is one of them that hasn't expanded.
Yes.
And so you've seen this happen across the states, and they're still having problems and issues. And it seems like those that are on Medicaid, I've seen some research out there that says, the results, the outcomes that they're getting are not much better, if any better, than not having insurance at all. And it goes back to this value proposition of what exactly is going on here. And so I wonder what your thoughts are on Medicaid and maybe some reforms that we should do.
Sure. So whenever you're talking about Medicaid or even certain health plans that are either through the Affordable Care Act or that are commercially available, what you have is a real problem with providers not accepting that insurance as coverage. And so you can have an insurance card, you can have a Medicaid card, you can have an exchange insurance plan, and even an employer plan in some cases. But if you don't have providers in the network willing and able to provide services under contract with those insurers, you are out of luck. You will either have to wait a very long time for an appointment, or you don't really have coverage except in an emergency situation. There are a lot of families and individuals who have a card but don't actually get care with that coverage. So a lot of what can be done at the state level is working on what's called the supply side of healthcare, which is what you mentioned, these rules and regulations that in many cases artificially limit the providers that are available. For example, there are a lot of laws called certificate of need laws that still exist in the states, where a would-be competitor has to go to a board which is composed in many cases of their would-be competitors to ask for permission to set up shop. So can you imagine if Whole Foods had to ask Trader Joe's or H-E-B or Walmart if they could sell groceries?
Yeah.
It's absurd. It would never happen. But yet that's how the healthcare system functions. We've also got a lot of limits placed on mid-level providers in healthcare. For example, nurse practitioners who may be educated and trained to carry out certain duties and procedures, yet because state law does not allow that, they aren't able to do it. And in many cases, and I've been through many of these scope of practice fights at the state level, in many cases it's the would-be competitors, like for example physicians, saying no to nurse practitioners. It's dentists saying no to mid-level dental providers. And so you really do have a lot of cronyism at work when it comes to these laws. Now, when we're talking about what states can and should be doing, we've got a real reckoning with the graying of our country. We've got a lot of demographic changes that are occurring, an aging population. And when we talk about caring for individuals in old age and that states pay for this, we really are, in a situation where states absolutely need to prioritize solutions that allow people to, for example, age in place, have lower cost care, different than nursing home if they don't absolutely need it. Things like remote monitoring of diagnostics, allowing for more telehealth. I mean, there really are a lot of solutions that can be applied to help keep people in their community longer, which is actually where they want to be, but also, where they will remain healthier and happier for a longer period of time, potentially, and hopefully surrounded by loved ones, as opposed to going into a nursing home, which is tens of thousands of dollars a year per resident. And unfortunately, in some cases, the quality of that care is not very good. So states need to think about how the aging demographics are going to impact their budgetary bottom line. These costs will squeeze out education, transportation, other budgetary priorities. It will happen, and that is why states need to act before there's an absolute crisis, but it's coming. So that's going to be really important, I think, going forward in reforms. In addition, there are a lot of opportunities to allow for example, direct primary care so that it's not regulated like insurance. It's more like a gym membership. And in fact, Medicare could allow for direct primary care as well as a federal reform. And that would be very beneficial. So for example, I pay, I think, about $75 for myself and then about $50 per child for each of my two kids per month. Maybe it's less than that, but I think it's less than that. I think I pay under $150 a month for the three of us to have access to our direct primary care provider so we can get our annual labs done without having to wait for weeks for an appointment, without having to sit in urgent care for 3 or 4 hours with a room full of people who are coughing. So it really is a nice solution. And it's, I'm very fortunate in that we do have employer-based policy, but even for people who, for example, work hourly jobs or maybe don't have an employer plan, it can still work really well for them. And I know from my direct primary care provider, he's been able to switch people to mail order medicines and actually save them with the equivalent of a mortgage payment per month because of getting better prices on the drugs that they need. And so we've really got a lot of opportunities at the state level to make things better, to allow for more access and more affordability. And when we think about, the actual cost of checking if someone has a flu, do they really have to go to make a doctor's appointment, go into the office, spend $100 minimum for that appointment, maybe more, when they could possibly go to a pharmacist and get that same test? We now have some tests that are available to do at home, which is wonderful. But in many states, pharmacists are not allowed to use those tests. So it's just, we've really got a lot of potential reforms. One of the reforms I'm most excited about is telehealth and the ability to provide care to people where they are and at the time and in the manner that's most convenient to them, which is really helpful. And then of course, artificial intelligence being applied to healthcare, not only on the systems operations side, but also on the care side. And so I think that we're really moving into a time where there's going to be a lot more opportunity for medical innovation and for better care for individuals as well.
Yeah, no, definitely. And that was one of the things I wanted to talk to you about. And right before we do that, I think that there could be some concern at the state level, right, with the amount of funding from the federal government. I mean, this is one thing I talk quite a bit about is budgeting, right? In the federal budget, running expected $2 trillion a year in deficits for the foreseeable future. $1 trillion a year is just net interest payments on the debt. So we're just rolling over debt with new debt. There's a lot of issues there. And at some point, we're going to have to face the facts that we can't continue to live above our means when it comes to the federal level. And that there are costs. We're seeing that now with inflation, higher interest rates, mortgage payments going up. I mean, all this is connected, folks. And a lot of it is driven by the healthcare cost of Social Security and Medicare. A lot of Republicans have been hesitant to focus on those, but I think we need to. We must for the foreseeable for the future. But also on Medicaid, I think, and I'd love to get your thoughts. I think one of the areas that the federal government will probably cut first will be some of the funding to states. When they're forced to look at all of their budgetary items of what they're funding, I think one of those will be Medicaid. And so what happens to that share where you have some states like Louisiana, where I do a lot of work with the Pelican Institute? I mean, almost half their budget is from the federal funds. Texas and other states, it's like 33%, which a lot of that is dominated by Medicaid funds. If that is cut, that would mean that the state would either need to come in and fill that void, which means maybe higher taxes, spending cuts in other areas, a lot of budgetary issues. It kind of goes back to the fiscal parts of it. But I wonder what you've been looking at with some of your thoughts, in research.
Well, I think one of the issues is there has not been very strong leadership from a more fiscally conservative position. And in order to make those cuts, in order to make them sensible, in order to allow states to transition to that, I think there needs to be very clear and strong leadership that basically says, like, we're not going to pay Medicaid based on how much you're spending. We're going to pay based on the value of that care that's provided. So for example, you might have New Jersey, which I'm just throwing this out, I don't know if this is real, but maybe triple the cost of what a better managed Medicaid system spends per patient. And let's say that the better managed system actually produces better outcomes for those patients. So we cannot continue spending just because it costs a lot in a state. We cannot continue spending based on that. We have to have parameters around, for example, do you allow nurse practitioners or other allied health professionals to perform services that can be billed at a lower cost without sacrificing quality of care? And the answer is yes. It absolutely can be done, and it is being done in many states. But for the states that haven't done it yet, they face no incentive to change, and so that's going to be very important. Another, and as I mentioned, making decisions that from policy decisions that allow for things like telehealth, for remote monitoring, for and I'll be clear on this. I mean, not everything is going to cost less. Not every single thing will cost less. Sometimes things do cost more, or sometimes utilization increases because more people are getting care. But that's, that is something that we should welcome as well, within certain parameters, of course. Whenever you have the misalignment of spending to those states that do not reform, that do not want to offer higher quality at a lower cost, or same quality at a lower cost even, we're not going to get very far until we're willing to stand up and say, no, we need to implement better ways of doing this. And you can certainly do it, say you've got 5 years, for example, to get your act together. We also have the benefit of technology now that we didn't have before. So, for example, you can do a telehealth visit, let's say $30, when a doctor visit might cost far more. That's an impactful change. Obviously, not every visit can be telehealth, of course. Sometimes the doctor does have to have hands on the patient to properly evaluate them, but not every single encounter requires that. So we really do need to do a better job of making clear that there is an expectation for states to be good stewards of these taxpayer dollars that are being sent to them to care for patients. One of the really interesting projects I've done in the past that I'd like to get back to is really quantifying what we spend on healthcare. There's this idea that that the reason that people don't have good healthcare is because we don't spend enough money, and that's absolutely false. There are dozens of federal programs, multiple state programs, even local programs that go towards healthcare. Unfortunately, a lot of those dollars don't end up caring for patients. They end up in administration, for example. They end up with, a regular office might have multiple people just fighting with insurance companies to get something covered. Not $1 of that is actually caring for the patient. And so the very large bureaucratic, bloated bureaucracy around spending these healthcare dollars also has to be very closely examined, because when you take a look at a state and you see that the average uninsured person per capita there are more dollars for that purpose, for that goal, than what, even some privately insured individuals are spending. We know we've got a real disconnect in terms of resources and outcomes here. The idea that, Medicaid is the only care that people get is absolutely not true. There are dozens and dozens of programs that operate in states that operate directly with federal taxpayer dollars that are supposed to be caring for people that aren't, that they're going somewhere else into this black hole of administration and bureaucracy. And so how many cents of each dollar is actually reaching the patient? That's a really important question that we need to be asking and answering when we take a look at reforms. Every single time someone talks about reforming Medicaid payments to states, you have governors going to Capitol Hill and crying their crocodile tears and talking about how they're going to they're going to lose all of these jobs. They're going to, it's going to be an economic catastrophe. But no one really talks about what is happening to patients who aren't getting the care that they need. There's no accountability for that.
No, that's exactly right. And that's unfortunate too, because they have it in their interest as the rent seekers, the politicians want to get reelected. So they need to keep bringing home the bacon, but the bacon may not be any good, is what you're telling me, and
or maybe you should stop eating bacon and eat some vegetables and fruit.
Right. Yeah, it's so interesting because the two kind of biggest sectors of our economy that have so much influence on our lives, and I think rightfully so in a lot of ways, are the ones that cost the most. Mark J. Perry at AEI always has this chart of the century where he shows, different prices that are going up and some that are going down, and some of the highest ones that have went up over time, I think it's since 1980 or whenever he starts it, but over time, has been in healthcare and education. But the ones that have less government influence and more technology, like you were getting at, those are the ones that are going down, like autos and TVs and different things of that nature. And so what I think we need is more competition, is what kind of this discussion has been about today. I think that'll be so important, whether it's on the supply side, on the demand side. And it's something that's interesting, going back to your first points, Naomi, was that, what did you say, 5% of the healthcare market is actually cash payments? So that really is the only area that you could think of as being kind of quote unquote a free market. That means 95% of it is essentially a government run system, much like government schools. In the government schooling system, you talked about all the bureaucrats in the health administration. We have the same number of bureaucratic problem in the education system. And neither one of these two big parts of our lives are getting worse outcomes, or at least not any better outcomes, with the amount of money that we're spending. And so it's something that really we've got to do something about. And I'm so glad you're working on this because it's really important. And so in our last couple of minutes here, what else would you like to say or kind of close out on for the audience?
Well, I'm really excited about the future of healthcare and the future of medicine. We really are seeing an acceleration in innovation happening. And I think that's great news for us. For example, we've got breakthroughs in medicines to cure diseases that, even 1 decade ago were death sentences. And so this is fantastic news. I do a lot of work to allow people to access treatments that have not yet received the FDA green light, for example, additional pathways to getting treatments. I'm very excited about the potential of telehealth as well as AI to make our lives better, to make it easier for us to get rapid and accurate diagnoses, no matter where we live, no matter what our zip code is, no matter whether or not we live near a university research medical center or not.
Yeah.
So really, this diffusion of technology to people who in the past didn't always have access to high quality care, I think is incredibly important. And the ability now to share information, for example, a rural hospital in the desert of Arizona, a community hospital where you've got really caring providers, but you don't actually have a stroke specialist, can now much more easily coordinate with the nation's leading stroke specialists to provide better care for their patients. This is all great news. It allows us to have higher qualities of lives, live longer, less patient suffering, for example. But these are things, though, that we do have to work towards getting government out of the way, making sure that lawmakers are allowing for more access and affordable options for patients and for collaboration. I mean, really, what we need to do is to create more fertile ground for innovations and progress in these areas. But I'm very optimistic that we are moving in that direction, and we're moving there quite quickly. And so I look forward to, what the next decade or two hold for us as individuals, and especially, to have a higher quality of life for longer.
No, it's great. And I feel more uplifted now. And so I like the optimistic, the courage and everything else that you've been able to do. Continue that, Naomi, and God bless you and your family, and keep up the great work.
Thank you.
Awesome. Well, it's been great having Naomi on today. For the audience, if you like this, please go out and be sure to subscribe to the Let People Prosper show wherever you get this podcast, and give us a 5-star rating. That would be great as well. And don't, I'll be sure to put all this in the show notes so you can find out all the information out about Naomi and some of her research and other things, so that way we can continue to have a better healthcare system and better lives and everything else. And until next time, let people prosper.